Welcome to a basic introduction to mechanical ventilation. This is chapter 3.2, Troubleshooting the Oximeter. If you've ever used a pulse oximeter, you know by now that there are problems with the measurement or with the device. The problems you encounter are frequently bad waveforms, and also you can run into problems with false highs and false low numbers. One of the most frequent issues is a bad waveform. If the waveform doesn't have the same general appearance as an arterial waveform with a notch at the top, then you have to consider the possibility that your waveform is bad and the numbers that it is generating are not accurate. Poor placement can occur if it is not properly attached, and this by far is the most frequent cause. It is important that the emitter and the detector are lined up and facing each other in order to have a good signal. So if the patient's tissue is too thick, or if there's light pollution, you may have trouble getting a decent signal. Another common cause is having the blood pressure cuff on the same side as the pulse oximeter. But usually you'll figure out what's going on pretty quickly. Now, if the probe is not securely attached, then you can also have problems with motion artifacts that can cause this poor waveform. More concerning, though, is when you have a poor waveform on the basis of hypotension or low perfusion or even hypothermia that can cause a bad waveform because of vasoconstriction. In this case, what you're better off doing is moving the probe to a better location, such as another finger or the earlobe or forehead if you have those types of probes available. Unusually, you can get a falsely normal or artificially elevated oxygen saturation reading. The most common circumstance you're going to encounter this is in carbon monoxide poisoning. So this is a population you need to be aware of, especially the burn victims and people who were enclosed space casualties who are particularly prone to carbon monoxide poisoning. The vast majority of commercial oxygen saturation probes use a wavelength of light that can't distinguish between oxygenated hemoglobin and carbon monoxide poisoned hemoglobin. Therefore, it reads an elevated or normal oxygen saturation even though a large percentage of the hemoglobin is bound to carbon monoxide. Therefore, a significant desaturation can be masked by this artifact. If you're ever in doubt about whether or not the oxygen saturations are artificially high because of carbon monoxide, then the best thing to do is to increase the amount of oxygen being delivered and get a proper arterial blood gas, as most commercial freestanding blood gas machines have co-oximetry, which means they have the ability to distinguish between carbon monoxide bound hemoglobin and regular oxygenated hemoglobin. There are some rare cases where there's a falsely low oxygen saturation, but for the vast majority of the times you should always assume that the desaturation is due to a patient problem and not the equipment. Also, if the probe had been accurate up until the time the desaturation event occurred, then you should assume that the problem is with the patient and not with the probe. Too many times I have seen fixation error where everybody watches the desaturating patient and plays with the sat probe instead of actually dealing with the patient who is having a problem. Some causes of falsely low readings include methemoglobin, severe anemia, skin pigmentation, light pollution, nail polish, and intravenous dyes. Rarely, there are patients who are born with a condition or are exposed to toxins that cause methemoglobinemia. This is essentially a proportion of the hemoglobin that is inactive and is unable to bind to oxygen. The problem is that it absorbs light in both wavelengths, so the pulse oximeter misinterprets the information it receives at the detector, and it can cause either an artificially high or low oxygen saturation. The clue is that the patient is cyanotic, and when you measure the PaO2, it's actually high. Recall that the PaO2 is a measurement of the oxygen that's dissolved in the blood and not bound to hemoglobin. When you compare the PaO2 and you see that there's a low oxygen saturation, you need to be suspicious that there's something off, because when the PaO2 is high, oxygen saturation should be 100%. You should recall this from the oxygen dissociation curve. The vast majority of hospital arterial blood gas machines are able to measure methemoglobin levels, so the diagnosis is usually pretty easy when you get a simple arterial blood gas. Severe anemia, usually below 50 grams per liter, can give you a falsely low oxygen saturation. In these cases, the hemoglobin saturation is actually normal, but it's just that there's not enough of it to go around. There is a myth that skin pigmentation can cause a falsely low oxygen saturation level. Now, the vast majority of people will actually have a very accurate oxygen saturation regardless of their skin color. However, if the skin is really dark, then the oxygen saturation is probably accurate, but the error range hasn't changed from 1 to 2% up to as high as 4%. So remember, when you see somebody with a dark skin color who has a low oxygen saturation, you should always assume that it's not the skin pigment that's causing the low value. Occasionally, ambient light sources can have light that's also in the same wavelength as the oxygen saturation probe is generating and can confuse the detector. In this case, the confused probe will read a constant oxygen saturation of 85%. Another myth is that polish and gels can cause poor readings. In fact, the vast majority of nail polishes don't do anything to the oxygen saturation unless they happen to absorb light in the same range as the oxygen sat probe emitter. Interestingly, red color usually has no effect whatsoever. Some brown nail polishes have been known to drop the oxygen saturations by 2%, but usually not much more. But if you're really worried, just take the polish off. Finally, some dyes that are given intravenously, such as methylene blue, which is used to treat refractory shock and also, ironically, methemoglobinemia, can give a falsely low oxygen saturation as it absorbs light in the same range as the light emitter is using. But these dyes are very transient, and so the effect is transient and quickly clears the body, and the oxygen saturations will return back to their normal levels.